Thank you, Dr. Zariba. Thank you, Wojciech. I would like to continue our discussion. Let me just share. You all see my screen, right?
Yes.
Okay. So this is a very important topic that we have been dealing with for the past 30, 20 years. The fact that we observed that the clinical course of LQTS, men and women, appears to be different. During childhood, there's a higher risk of arrhythmic events and cardiac events in males, but there's a risk reversal after the onset of adolescence, when the risk appears to be increased in women. And the only one of the possible options, that this is an effect of sex hormones. And we have studied this extensively over the past years. And we have now even used, with your help, with the registry patient help, we have also now identified a novel finding looking at the effect of all contraceptive use in women with LQT syndrome. And I'm going to describe this. This was submitted as a late breaker, was presented recently at the Heart Rhythm Society meeting. And Dr. Wilde, I was actually the main reviewer and the editor handling this manuscript. And this study was supported because this is such an important thing that needs to be analyzed and looked at, was supported by the American Heart Association, big grant for sudden cardiac death, statistically focused network. So it's a whole big network focusing on sex differences in the risk of sudden cardiac death between men and women. So as I mentioned, women with congenital LQT syndrome experience a significant increase in the risk of cardiac events after the onset of adolescence, but also during the postpartum period after giving birth and during the perimenopausal period. On the other hand, the risk of cardiac events among men appears to be attenuated after the onset of adolescence. And this can only be possible due to the modulating effects of sex hormones on those potassium channels associated with LQT syndrome, those mutations. As you see here, as I mentioned, before the onset of adolescence until the age of 12, the risk appears to be higher among males. But after testosterone comes into play, estrogen, progesterone, there's a risk reversal. Testosterone appears to be protective, and estrogen and progesterone may be increasing the risk, especially estrogen, as we have found out. And this is even a more severe endpoint of life-threatening event, even close to sudden cardiac death, again showing that LQTS boys appear to have increased risk before the onset of adolescence, but after that, there's a risk reversal, and women appear to have the higher risk of life-threatening cardiac events and sudden cardiac death. And this is something that I mentioned. We looked during pregnancy and after giving birth, during the 6 months after giving birth, we see that the risk of cardiac events is very high after giving birth. During pregnancy, it's not really increasing, but after giving birth, it becomes very high, especially with women with congenital LQT, LQT2. LQT2 women have a very high risk of life-threatening events and cardiac events after giving birth during the postpartum period. And the same goes for during the perimenopausal period. So there are two main interesting findings. First of all, the fact that there's a risk reversal. Women after the onset of adolescence have a high risk, possibly due to the effect of estrogen, and men have a low risk because possibly testosterone is protective, but the most sensitive ion channel appears to be in LQT type 2. And this is also very interesting. If you look at QTC after the onset, after puberty, you see that there's, especially in women, there's an increase in QTC, especially in LQT2, after the onset of puberty, and after menopause, there is a reduction in QTC, whereas in LQT1 and in healthy individuals, there's not such a pronounced increase in QTC during lifetime after the onset of puberty. And this is the normal menstrual cycle. You see that estrogen that may increase the risk appears during the follicular phase until the middle of the menstrual cycle, and there's higher levels of progesterone. And we are studying these effects of QTC, of progesterone and estrogen on QTC using your collaboration in a clinical study funded by the American Heart Association. And these are the effects of synthetic hormones or contraceptives. You see that the level of sex hormones is very high and very stable throughout the menstrual cycle when we use oral contraceptives, and then it goes down, and these are the basal level of hormones in women who use oral contraceptives. So there's a high level of synthetic hormones and very low levels of basic hormones or internal hormones, and that also increase during the time in which oral contraceptives are not being used. And now we need to better understand how oral contraceptive may affect QTC. And we see that fourth generation oral contraceptive, especially those who have progesterone, but also have, because progesterone is associated with very androgenic effect, in the new generation of oral contraceptives, there's also a component of anti-testosterone. So what will anti-testosterone component do? It will increase the risk. So progestin, fourth generation, even though progesterone may be protective, the fact that now the newer generation of drug incorporate anti-testosterone, it may increase the risk of arrhythmic events and congenital long QT syndrome. So this could be very interesting. And this is the reason we use this data to analyze how oral contraceptives affect the risk of cardiac events in women with congenital long QT syndrome. So this use of oral contraceptive represents a therapeutic model with a very high content of sex hormones relating to the proportion of progesterone, estrogen, but also testosterone in each formulation, and anti-testosterone, anti-androgenic effects. And for this, for the first time, we carried out a clinical study to evaluate the safety of oral contraceptive by the sex hormone content in long QT syndrome. So the aims of this study was to evaluate the association of oral contraceptive formulation categorized by progestin only, but remember that progestin only also incorporates anti-testosterone effects, estrogen only, and combined with the risk of cardiac events in women with congenital long QT syndrome. We also wanted to know whether beta blocker therapy, beta blockers that you all may use, may protect during oral contraceptive use against the risk of cardiac events, and to evaluate the effect of oral contraceptive on the risk of cardiac events by LQTS genotype. Because as you remember, LQT2 women appear to be more affected by sex hormones. For this study, we used again your collaboration, and we sent out a questionnaire by Chris, Bonnie, and Becky. We sent out a questionnaire, and to date, more than 1,600 women from our registry completed the questionnaire that formed the basis of this study. And we look at the association between oral contraceptive use and the risk of syncope, abolic cardiac arrest, LQTS-related sudden death, and ICD shocks in women with congenital long QT syndrome. So first of all, among the study women, we see that 370 use oral contraceptive at any time, and we see the distribution of oral contraceptive use, going back, is estrogen only 20%, progesterone only 22%, and combined 57%. And again, remember that progestin only also incorporates anti-testosterone effects that may increase the risk. And again, looking at adjusted analysis, we see that as we possibly may expect because of those anti-androgen effect, anti-testosterone, women who use progesterone only effect, fourth generation, had more than a 2.5-fold increase in the risk of cardiac events during oral contraceptive use. We see this in the figure. Progestin only oral contraceptive was associated with the highest risk of cardiac events during follow-up. and especially among those who did not use beta blockers. So beta blocker therapy, that the risk was more than a threefold increase in the risk of cardiac events, whereas beta blocker therapy was actually protective during use of oral contraceptives. But again, progestin-only oral contraceptives were associated with the highest risk among women who did not use beta blockers, but beta blockers appear to be protective in this population. And we see that progestin-only oral contraceptive use was associated with the highest risk of cardiac events, but this is among women who did not use beta blockers. Whereas those who use beta blockers, you see there's no increase in the risk of cardiac events during progestin-only oral contraceptive use. But the risk of cardiac events was most pronounced, as we expected, in women with LQT2, more than 8-fold increase in the risk of of cardiac events among women who use progestin-only oral contraceptives, but also among those who use estrogen-only oral contraceptives. So again, LQT2 women, as we have shown in the past, are very sensitive to levels of sex hormones, and in this population, it may not be advised to use oral contraceptives. So in conclusion, we believe that this study has shown that women with congenital LQTS syndrome who are treated with progestin-only oral contraceptives, especially those who have high levels of anti-testosterone effects, experience nearly a threefold increase in the risk of cardiac events when not treated with a beta blocker, and the risk associated with this oral contraceptive use appears to be most pronounced among women with the LQT2 genotype. And our findings suggest that progestin-only oral contraceptive use, especially the fourth generations one with anti-testosterone effects, should not be administered in women with congenital LQTS syndrome without beta blocker therapy together. And careful consideration should be exercised when prescribing any oral contraceptive to women with LQTS syndrome. We're also going to continue study to assess the clinical implication of our findings to patients in a germ population, also are prescribed drugs that may prolong the QTC duration. Thank you.
Thank you very much, Ilan.